చెప్పు మళ్ళీ ఇక్కడ
Good morning, students. Today we'll continue with the rest two topics of lens. Pranav Teja, are you ready?
Yes, ma'am.
You can start your presentation. Share your screen. You have to on your video also.
Ma'am, is it visible, ma'am? Ma'am, shall I start, ma'am?
Oh, yes.
Hi, this is Pranav. My topic is senile cataract, etiology, classification, and stages of maturation of senile cataract is my topic. Let's start into topic. Cataract. As of today, the term cataract refers to development of any opacity in the lens or the capsule. Cataract thus may occur either due to formation of opaque lens fibers that may be congenital and developmental cataracts, or due to degenerative process leading to opacification of the normally formed transparent lens fibers. Cataract may occur either due to formation of opaque lens fibers or due to degeneration of normally formed lens fibers in the afterlife. Age-related cataracts. It is the most commonly occurred, and the classification is divided into morphological and maturity classification. Morphological classification is nuclear type, cortical type, subcapsular, and mixed nuclear and cortical cataracts. Maturity classification, they are immature cataracts, mature cataracts, and hypermature cataracts. Cataract occur due to disturbance in the formation of lens, while in acquired cataract, opacification occurs due to degeneration of already formed normal fibers. Senile cataract is an acquired type of senile cataract. So age-related cataract is also called as senile cataract. This is the common type of acquired cataract. Both males and females are equally affected. It is usually seen above 50 years. Senile cataracts are usually bilateral, but almost always one eye is affected earlier than the other. Etiology. Age. Usually senile cataracts occurs after 50 years of age. When it occurs before 45 years, it's pre-senile cataract. On an average, about 60% by the age of 60 years and by 70% chance by the age of 70 years. Sex. Both sexes are equally affected. Some studies show females are more prone when compared to males. Hereditary also plays a role in cataracts. Ultraviolet irradiations, more exposure to UV radiation from sunlight have been implicated for early onset of senile cataract. Dietary factors, dehydration crisis, and smoking is also responsible for the causes of senile cataracts. Causes of presenile cataracts. The term presenile cataract is used when the cataractus changes similar to senile cataract when occurs before 45 years of age. The common causes of presenile cataracts are hereditary. As mentioned above, because of influence of hereditary, the cataractus changes may occur at early age in successive generations. Diabetes mellitus is also a reason for presenile cataract. Age-related cataracts occur earlier in diabetics. Nuclear cataract is more common and tends to progress rapidly. Myotonic dystrophy is associated with posterior subcapsular type of presenile cataract. Christmas tree cataract is typically seen in this condition. Atopic dermatitis may be associated with presenile cataract in 10% of cases. Concept of sin and co-cataractogenic factors. It has been conceptualized that cataract is a result of multiple subthreshold cataractogenic stresses acting in concert. Age has been implicated as one of these cataractogenic stresses. These stresses and that superimposition of other toxic stresses on aging lens may accelerate the rate of cataract formation. That means these stresses may causes cataract formation in the earlier age. Conversely, the elimination of one or more cataractogenic stresses may delay the cataract formation. Mechanism of loss of transparency of the lens is basically nuclear and cortical type of senile cataracts. Whereas when we see the cortical type of cortical senile cataract, its main biochemical features are decreased levels in the crystalline lens of total proteins and amino acids, and potassium associated with increased concentration of sodium, and marked hydration of lens, followed by coagulation of lens proteins. Uh, this is the uh, this is this is the pathway. With increasing age, there is decreases in the function of active transport pump mechanism of lens, ultimately causing hydration of lens fibers. And aquaporin or MPP mutation are also responsible. Reduced oxidative reaction ultimately leads to decreased synthesis of protein in lens fibers. All these conditions leads to denaturation of lens proteins, which causes opacity in the cortical lens fibers. Nuclear senile cataract. In this, the usual degenerative changes are intensification of age-related nuclear sclerosis associated with dehydration and compaction of the nucleus, resulting in hard cataract. It is accompanied by significant increase in water-insoluble proteins. However, the total protein content and distribution of cations remain normal. These may or may not be associated. Deposition of pigment, urochrome and melanin derived from the amino acids of the lens. Stages of the senile cortical cataracts. There are 5 stages: lamellar separation, incipient stage, immature, mature, and hypermature. These are the stages showing the diagrams. Stages of maturation of senile cataract. The first stage is lamellar separation. The earliest sign of senile cataract is formation of vacuoles and water clefts in the anterior and posterior cortex. This leads to demarcation of cortical fibers owing to separation by fluid. This phenomenon of lamellar separation can be demonstrated by slit lamp examination only. These changes are reversible. Stage of incipient cataract. In this stage, early detectable opacities with clear areas between them are seen. Two distinct types of senile cortical cataracts can be recognized at this stage: cuneiform stage and cuneiform stage. First, cuneiform senile cortical cataracts. It is characterized by wedge-shaped opacities with clear areas in between them. These expand from equator towards the center in early stages, can be only demonstrated after dilation of the pupil. They are first seen in the lower nasal quadrant. These opacities are present both in anterior and posterior cortex and their apices. Slowly progress towards the pupil. On oblique examination, cortex these present a typical radial spoke-like pattern of grayish-white opacities. On distant ophthalmoscopy, these opacities appear as dark lines against the red fundal glow. Since the cuneiform cataract starts at the periphery and extends centrally, the visual disturbances are noted comparatively in the late stage. Cupliform senile cortical cataracts. Here, it is a saucer-shaped opacity developed just below the capsule, usually in the central part of the posterior cortex, which gradually extends outwards. There is usually a definite demarcation between the cataract and the surrounding clear cortex. Cupliform cataract lies right in the pathway of the axial rays and thus causes early loss of visual acuity. Immature senile cataract. In this stage, opacification progress further. The cuneiform or cupliform patterns can be recognized till the advanced stage of ISC when opacification becomes more diffuse and regular. Lens appears grayish white, but cortex is clear and still present. Iris shadow is visible. In some patients at this stage, lens may become swollen due to hydration. This condition is called intumescent cataract. Intumescence may persist even in the next stage of maturation. Due to swollen lens, anterior chamber becomes swollen. Mature senile cataracts. In this stage, opacification becomes complete. Complete cortex is involved. Lens becomes fairly white in color. Such cataract is also called as ripe cataract. Hypermature senile cataracts. When the mature cataract is left in situ, the stage of hypermaturity comes. The hypermature cataract may occur in 2 types. Most important is Morganian type hypermature cataract. In some patients, after maturity, the whole cortex liquefies and the lens is converted into a bag of milky fluid. The small brownish nucleus settles at the bottom, altering its position with change in the position of the head. Such cataract is called Morganian cataract. Sometimes in this stage, calcium deposits may also be seen on the lens capsule. This is the image showing Morganian cataract, and lens on the lens showing cortex liquefaction. The arrow shows the lens sclerotic type hypermature cataract. Sometimes after this stage of maturity, the cortex becomes disintegrated and the lens becomes shrunken due to leakage of water. The anterior capsule is wrinkled and thickened due to proliferation of anterior cells, and dense white capsular cataract may be formed in the pupillary area. Due to shrinkage of lens, anterior chamber becomes deep and iris becomes tremulous. Maturation of nuclear senile cataract. Progressive nuclear sclerotic process renders the lens inelastic and hard. Its ability to accommodate and obstructs the light rays. These changes begin centrally and slowly spreads to peripherally, almost up to the capsule. When it becomes mature, however, a very thin layer of clear cortex may remain unaffected. The nucleus may become diffusely cloudy or tinted due to deposition of pigments. In practice, the commonly observed pigmented nuclear cataracts are either amber, brown, that is cataracta brunscens, or black cataracta nigra, and rarely reddish cataracta rubra in color. Thank you. Ma'am, come.
So you did not make your presentation is nice, Pranav Teja, but you missed out a few topics like the how to differentiate between immature, mature, and hypermature cataract clinically. How to differentiate between all these?
Nuclear cataract from partial cataract, and also differentiation. These are the things normally we ask in the exam. Understand?
Can you mention a few differences now? How to differentiate between cortical and nuclear cataract?
These are the things normally we ask you in the examination. When we are doing actually a seminar, now we are supposed to read a little more than the graduation level. Okay. So the same topic we teach actually to the nursing students, paramedical ophthalmic assistants, undergraduates, postgraduates, and even fellows. So at least when you are presenting a seminar, your topic, your preparation must be to the level of at least a newer candidate. So if they don't know the common, the normal cortical cataract, these are the questions which we commonly ask in the examination. The differences you must be able to mention. I will calculate by the side and I will read it out.
You have textbook by the side, Yana? By your side now? Pranav,
No,
do you
no,
have
ma'am.
textbook?
Actually came to my uncle's house. Actually don't have Wi-Fi in home, so I came to my uncle's house.
So what is the pigment which get deposited in nuclear cataract? You wrote just pigment deposition occurs. So what are the various pigments that get deposited?
Eurochrome and
what complication you expect due to intumescent cataract? You said intumescence is seen in immature cataract. So what complication can occur at that stage? Intumescence is present. What are the various lens-induced glaucomas?
ma'am, I can't hear, ma'am.
What are the various lens-induced glaucomas?
Lens-induced glaucoma, sir.
You are hearing it for the first time?
No, ma'am, I forgot.
And morphological classification of cataract, can you just once again mention? You have not completed the classification in your PPT. Morphological classification.
Cortical type, nuclear type, and mixed type. ma'am.
That's all. So what is anterior capsular, anterior subcapsular, polar, posterior subcapsular?
Cuneiform is also called as subcapsular cataract. Cuneiform is most common. 75% cuneiform and 25% nuclear, and 5% cuneiform cataracts are commonly seen.
Okay. Okay, Pran.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Gayatri Varsha,
Yes, ma'am.
are you ready?
Yes, ma'am.
You share your screen and start your presentation.
Start your video also. We'd like to see your face.
Yes, ma'am.
Oh, yeah, not seen anywhere. That's fine.
Ma'am, it is visible now.
This is the
Good morning, everyone. My name is Gayatri, and I'm going to present ocular anesthesia. So basically, anesthesia for eye surgery presents many unique challenges. And basic definition of anesthesia is it is defined as a reversible loss of feeling or the sensation, that is specifically the loss of pain or sensation induced to permit to perform surgery or other procedures which are otherwise painful. So it is classified into general ocular anesthesia and local ocular anesthesia. The choice is made on the basis of the duration of surgical intervention and the related skills and benefits of each technique for the patient. So actually the neither technique has shown to be safer till date. General anesthesia. So during general anesthesia for ocular surgery, use of relaxants, endotracheal intubation and controlled respiration is preferred. Under general anesthesia, one need to ensure that the patient does not develop carbon dioxide retention because choroid plexus swells to many times than the normal value. The normal value is 3.2 millimeters and ocular contents may also prolapse. So the indications for general anesthesia is major operations, infants, children, and people who are uncooperative and mentally retarded patients, anxious patients. So the limitations and the drawbacks are hypoxia, laryngospasm, respiratory depression, cardiac arrhythmia, hypertension. Now coming to the local anesthesia. Local anesthesia is used more commonly than the general anesthesia. So the local anesthesia is being employed with increasing frequency in ophthalmology. Its uses are it's clinically used to produce temporary loss of sensation, analgesia, and function. Protein bound receptors located near the sodium channel, and it causes a decrease in the depolarization of the nerve membrane. There are certain advantages and disadvantages. So the advantages are surgery can be undertaken as a daycare procedure. It provides a low intraocular pressure with dilated pupil and can be used to reduce the intraocular pressure vitreous volume when necessary. Disadvantages are it cannot be used in uncooperative patients or children, while the general anesthesia can be used in uncooperative patients, and it is also painful. So the mechanism of local anesthesia is it binds with the protein receptors of the sodium channels, which blocks the voltage dependent sodium conductance, which blocks the depolarization. Further, the initiation and the propagation of action potential fails. This leads to Afferent impulses cannot go to the higher center, which causes no pain. So the toxicity. Toxicity might take place because of overdosage and may cause lightheadedness, numbness or tingling of the circumoral area, anxious, drowsiness, tinnitus, convulsion, coma, and apnea, and cardiovascular collapse. The local anesthetics generally used are the commonly used are epinephrine, whose concentration is added to shorter acting drugs to retard the vascular absorption, and lidocaine, that is 0.5%, 1%, and 2%, which yields a rapid retrobulbar or eyelid block that lasts for 1 to 2 hours. Next is bupivacaine. It is a poor echinacea and has a longer duration of action, that is 8 hours. Its safe dose is 25 ml of a 0.75% solution. So the adjuvants are hyaluronidase combined with the local anesthetic agents to increase the dispersion when low volumes are used. So the hyaluronidase is generally given in the retrobulbar and the peribulbar blocks. Adrenaline reduces the systemic absorption by local vasoconstriction. It is used in a proportion of 1 in 1 lakh. The other local anesthetics which are rarely used are amitocaine and ropivacaine. So the local anesthesia is again classified into topical and regional. So the regional is further classified into peribulbar block, retrobulbar block, intracameral block, facial block, frontal block, parabulbar block, or the subtenon block. The other nerve blocks are intratrochlear block, supraorbital block, lacrimal block, infraorbital, and the zygomatic block. So the local anesthetic drugs used in the ophthalmology are tertiary amines linked by either ester or amide bonds to an aromatic residue. So the peribulbar block. Peribulbar block or the it is also known as the extracorneal block. These are employed for the intraocular anesthesia and analgesia, and nowadays it has also replaced the retrobulbar block. So its anesthetic volume, that is 6 to 7 ml, is injected into the peribulbar space. After injecting it, it spreads to the lid and other spaces, which leads to globe and orbicularis echinacea and anesthesia. So the local anesthetic agent in the peribulbar block used are lignocaine 2%, bupivacaine 0.5 to 0.75%, along with the hyaluronidase, that is 5 to 7.5 international units per ml, and adrenaline, that is 1 in 1 lakh. And the position of patient should be supine and is in the primary gaze. Volume is 6 to 7 ml. Insertion point is junction of medial 1/3 and lateral 2/3 of the upper lip, that is the first insertion point. And the second insertion point is junction of medial 2/3 and the lateral 1/3 of the lower lip and parallel to the orbital floor. So its uses are, it is the peribulbar block is used in cataract, glaucoma, keratoplasty, vitreoretinal surgery, strabismus surgery. And the advantages and disadvantages are, there is a less chance of globular injury and there is a less chance of optic nerve damage in the peribulbar block. Whereas its disadvantages are, it is painful, conjunctival chemosis may occur, and less echinacea than the retrobulbar block. So now coming to the retrobulbar block, it is injected in the muscle cone behind the eyeball to block the ciliary nerve and ganglion, third and sixth cranial nerves, and it produces echinacea, analgesia, and anesthesia of the globe. As the needle pierces the intermuscular septum between the lateral and the inferior rectus muscles, the feel is altered. And the site of injection is 3.5 centimeters long needle used transcutaneously at the junction of the middle and the lateral thirds of the lower orbital margin. The direction of needles is, first it is inserted straightly backward, then upwards and medially towards the apex of the orbit. So the volume is, after the aspiration, 2 ml of anesthetic solution is injected. That is, the composition is 2% xylocaine with hyaluronidase, 5 international units per ml, with or without the adrenaline. So indications of the retrobulbar block are, it is indicated in all the intraocular surgeries as in the peribulbar anesthesia, but needs additional facial block. The contraindications are bleeding disorder, extreme myopia, open eye injury, posterior staphyloma. And the advantages are complete echinacea, dilatation of pupil, adequate and quicker anesthesia, minimal amount of agent required. Complications are the retrobulbar hemorrhage, glow perforation, optic nerve sheath injury, optic nerve atrophy, reduced visual acuity. So the globe perforation can be avoided by the subtenon's block. Now the retrobulbar hemorrhage, which is a complication of the retrobulbar block. It is commonly due to advent puncture of vessels within the retrobulbar space. Simultaneously, appearance of an excellent motor block of the globe, closing of the upper lid, proptosis, and palpable increase in the intraocular pressure. It can lead to stimulation of the oculocardiac reflex, and the best course of action to postpone the surgery is for 2 to 4 days after the hemorrhage. The management, the retrobulbar hemorrhage can be managed by determining the intraocular pressure and by ophthalmoscopy. And the treatment is to reduce the intraocular pressure using osmotic diuretics, lateral canthotomy, orbital decompression. Next is globe puncture, which is also a retrobulbar complication, and the risk factors are high myopia, sharp injection needle, previous scleral buckling, inexperience in performing the local blocks, poor patient compliance. So now the parabulbar or the subtenon block. So this is also known as a pinpoint anesthesia or the episcleral block. And the conjunctival incision is 2 to 3 mm in size. It is halfway between the inferior limbus and the fornix to open the subtenon space. Here the blunt cannula is used to inject the anesthetic into the posterior subtenon space, which bars the nerves and muscles within the cone. The position of patient. The patient should be looking upwards and outwards. Conjunctiva and the Tennant's capsule are gripped with non-teethed forceps, that is Moorfield forceps, 5 to 10 mm away from the limbus, and a small incision is made with the Westcott scissors to expose the sclera. Volume. It varies from 1.5 to 11 ml. The commonly used volume is 3 to 5 ml. And the composition of the anesthetic agent used here is the lignocaine, bupivacaine, articaine. The lignocaine and articaine are 2% each, and bupivacaine is 0.5%, and the hyaluronidase either can be added or more. Now the frontal block. The main aim of the frontal block is to block the supraorbital and the supratrochlear nerves which are supplying the upper eyelid, and it is used in the ptosis surgery. And the site is below the midpoint of the supraorbital margin and given transcutaneously, and the volume is 2 ml. Now the intracameral block. The anesthetic agent used is 0.2 to 0.5 ml. Lidocaine hydrochloride 1%, which is unpreserved, and it is used for fecoemulsification. The absence of the posterior capsule, it might cause transient retinal toxicity, that is transient amaurosis. Now the facial block, and the main aim of the facial block is to block the action of the orbicularis oculi, and it is used as an adjunct to the retrobulbar block. The facial block is further classified into Van Lint, O'Brien, Nadbath, and Rahman Atkinson. So now the Van Lint's block, it blocks the terminal branches of the facial nerve, producing the localized echinacea of the orbicularis oculi with facial paralysis. 2.5 ml of anesthetic solution is injected in the deeper tissues above the eyebrow and below the inferior orbital margin. The second one is O'Brien's block. The facial nerve is blocked near the condyloid process. At this point, the needle is inserted until the contact is made with the periosteum, and then 4 to 6 ml of anesthetic solution is inserted. Next, Nadbat block. The facial nerve is blocked as it leaves the skull through the stylomastoid foramen. This block is also painful. The last one is Atkinson block. In its superior branches of the facial nerve are blocked by the anesthetic solution at the inferior margin of the zygomatic bone. Next is the topical anesthesia. So the topical anesthesia, manipulation of superficial cornea and conjunctiva, and it is used phacoemulsification in cooperative patient, and it is given prior to the regional blocks. So the commonly used topical anesthetics are lignocaine, paracaine, benoxenate, cocaine, and proparacaine. So the lignocaine is in concentration of 4%, paracaine and benoxenate is given as 0.4%. So the advantages and the disadvantages are the topical anesthesia is cost effective, least invasive procedure, and the compression of eye is not required in this, and the effect of anesthesia is immediate. Immediate visual recovery is also seen, and there is an avoidance of post-operative ptosis and sight-threatening complications in topical anesthesia. And the disadvantages are there is no echinacea and it is not suitable for extended surgeries. Proficient, experienced surgeons should be available and well informed and motivated patient, not suitable for anxious, deaf, and in those having dense cataract. And the adverse effects of the topical anesthesia are epithelial and endothelial toxicity, allergy to the drugs, tear film instability, and reduced reflex staring, and thus complicates the clinical picture in the dry eye patients. Surface keratopathy. Now the take-home messages are all the local anesthetic agents are mycotoxic. So the direct insertion into a muscle should be avoided. No local anesthetic technique is entirely free of severe systemic adverse events. Short, fine needle should be used. Eye in the gaze position. Eye should be in the gaze position. Gentle aspiration after insertion of needle should be done to alleviate the possible entry into the blood vessels. Bevel of the needle facing the globe and tangential to the sclera, and all the ocular surgeries with the local anesthetic should be treated as a general anesthetic. Thank you.
Gayatri, you have done well, but you didn't mention the indications for general anesthesia in Aplas. When do you actually advise general anesthesia? Most of the patients, they are done under local anesthesia only. There are certain specific indications for general anesthesia. What are they?
Local anesthesia, sir.
General anesthesia.
General anesthesia.
In which conditions? Where do you give actual general anesthesia? For intra-Aplas surgeries. What precautions actually you ask the anesthetist to take while giving general anesthesia? Ketamine, can it be used? Has it got any side effect?
So it's not clear, sir.
Ketamine, can it be used for actually initiating the general anesthesia? Okay, no problem. What are the indications for general anesthesia? Children, uncooperative
It is
patients,
uncooperative and mentally retarded patients.
psychiatric patients, mentally retarded, and so on. So these things also you must mention. Okay. And
I have
when
mentioned it, sir.
the surgery lasts for more than 2 hours, so your local anesthesia may not be tenable till then. In such
Sir.
conditions also, we may request actually general anesthesia. So the surgeries like eccentric, it is not very well. Previously, we used to give general anesthesia for those cases.
Yes, sir.
What happened? Are you normal? Are you okay?
No, sir. Little cold, sir.
Okay, good. You have done well. Thank you.
Thank you, sir.
Friendly से लिख कर कोई पता नहीं होने नहीं लिख कर
Next Wednesday.
next Wednesday.
So Monday being a holiday, so next two students you have to prepare for Wednesday. Okay. Navya and Fatima, you have to be prepared for your presentation on Wednesday. Thank you.